Comment I'd like to make in response to what was said earlier in terms of WHO flagging the countries that don't have access to data. So one of the things that maybe some of you in the room might not be aware, that the WHO is not what you think. It's not this building in Geneva. The building you may know in Geneva is actually the WHO Secretariat. And WHO is actually made of all the ministries of health in the world that actually sit together and discuss things. And we as a Secretariat have a mandate to help each and every country. So that's actually why we're here to help them and not to flag what they don't do right. That's actually why we don't finger point the countries that don't have data, but we try to work hard to help them, and behind the scene we approach countries that don't have enough data and try to help them. So this is what it's going to be about. And you also may think that I'm like a representative for a written document, but this is a one-page document that we've summarized, and it's actually available also at the coffee room. You will see here is the monitoring and evaluation framework, and here the data system that you need to make it happen. So this is as simplified as we're trying to make it happen. So in this, in the course of this talk, I will try to introduce this monitoring and evaluation framework to you. Then we'll be talking about the prevention indicators, the care and treatment indicators, and then try to see what tools do we have to actually measure the impact on the disease itself in terms of new cases, chronic infections, and mortality. So that's another way to present the global health sector strategy on hepatitis. As I mentioned earlier, it's a bit of the source code. So we have these 5 core interventions, and we assume that if we reach these targets by 2030, we will reach elimination as defined by the reduction in incidence and mortality. So for some of you who have experience working in HIV, we've actually carbon copied the monitoring and evaluation framework of HIV, which is for those of you who come from a public health background, as being put together in terms of what's called a result chain system. So here we start from the context, then the input, all the resources that we put in the elimination, then the output to the outcome, what our programs are going to deliver in terms of service coverage, and then the impact on disease. So here the main indicator to determine the situation is the prevalence of chronic infection. Then one of the key input is the testing capacity, because as was just mentioned, testing is really important, the diagnosis. Then we have prevention here with vaccine, harm reduction, and injection safety. And here the cascade of testing, treatment, and viral suppression or cure. And here we can have the impact in terms of incidence reduction, and here mortality reduction. So here you can see the natural history, in fact, is broken down here with the incidence, the chronic infections, and the mortality. And this is basically hepatitis surveillance, which sort of sandwiches the whole M&E framework. And in between, we have the prevention and the care and treatment. So to make this happen, and so what I've shown so far was this side of the sheet. On the other side of the sheet, you have the data system that you need to have in place to make this happen. So one, you need hepatitis surveillance that will look, that will place the electrodes along the natural history of viral hepatitis as a disease. So we need a system to monitor new infection, which are reflected by acute hepatitis, a system to monitor the prevalence of chronic infection, and a system to monitor the mortality. So this is being explained in that part of the sheet. And then we need program data on prevention, which is here, and care and treatment. So I will walk you through these aspects. So first, in terms of the prevention indicators, it's been underlined a number of times today that not only we need care and treatment, but if we don't turn off the tap of new infections, then that's a problem. So for B, we know very clearly that the key intervention is vaccination and prevention on the mother-to-child transmission, this being captured by the C3 indicators, whereas for C, the key intervention will be harm reduction and injection safety. So these program data, these prevention indicators program data, we don't have to reinvent the wheel. They usually are systems in place in countries to monitor these indicators. WHO and UNICEF publish national estimates of vaccination coverage. Injection safety indicators are usually monitored within the DHS, the Demographic and Health Survey. Blood safety standard indicator are usually reported to WHO as part of the global database on blood safety. And harm reduction indicator, they exist. Unfortunately, there's massive amount of underreporting. So there is a potential system, there is standardized indicator. The pipeline is sometimes, unfortunately, not filled with flowing information. So that's where it fits on that sheet. So now I will say a word of the Cascade of Care. So the C6 indicator is a proportion of those infected that are diagnosed, of which we have the C7 indicator, those that are either started on treatment for C or on treatment for B, and then the viral suppression or the cure, which is the C8 indicator. So this, on this aide-memoire, the explanation of what you need to monitor the cascade is explained in this part of the graph. So this is what we're proposing to do. We want to make sure that we have a patient-centered system that actually is at the crossroad of patient care and public health. So ideally, there should be some system of patient record, which could be a paper card or e-record, but that really captured all the critical event that needs to happen based on the standardized treatment guideline for the patient to be managed accurately. And if this is documented, then the second step is to build a patient database so that you can aggregate this data and constitute a cascade analysis. And so this is the pattern on how to make it happen is now quite clear. It's also carbon copy from HIV. What is not so clear so far is what's going to be the mechanism by which we're going to have this reported annually to WHO or maybe every 2 years. For HIV, for instance, we have a system called GAM, the Global AIDS Monitoring. So for hepatitis, we're not so clear as to what we are going to do, and we plan a consultation on this in the year 2018. For those of you who like science fiction, I would like to give you a preview of what elimination will look like. Not so much because I want to anticipate and I want to be overly optimistic, but just for you to understand that the B cascade and the C cascade actually function completely differently. So for B, it's a chronic care cascade. If you're familiar with HIV, it functions exactly the same way. We're going to put people on long-term treatment, and they're going to be suppressed in terms of viral replication. So ideally, if we're successful with elimination, you will see that the total number of people infected will reduce by a cohort effect, by some mortality, but not in a spectacular way. But in fact, it should be all those diagnosed and on treatment that will go up. So ideally, when we celebrate in 2030 the cohort, the cascade analysis for HBV should look like this. And that's extremely different from HCV, because HCV function like TB. So you put people on short-term curative treatment, and then they're removed from the pool of infected. So in fact, what's going to happen, and we're starting to see it a little bit in 2016 compared to 2015, by putting people on patients, it's a real cascade by which people will end up suppressed and they're completely removed from the total number of those infected. So that really functions very differently, and it means that our core indicator here is what we call a treatment initiation rate. So it's the speed at which we're managing to removing people from the pool of chronic infection. And when we're successful at getting people treated, then we are, I'm not sure where my pointer is, when we're successful at putting people on treatment, then we're also depleting the pool of diagnosed, like the colleagues in Egypt have found and learned the hard way, which means that if we want to continue the elimination initiative, we need to be also proactive with testing. So now that we've seen the way that we can monitor the indicators in terms of prevention and the indicators in terms of treatment, we'll focus on hepatitis surveillance, which will be the mechanism by which you can see all these interventions in terms of prevention and testing and treatment turn into less new infection, high affect the prevalence and also the mortality. So this is what's being explained in the upper part of the document. So to explain viral hepatitis again, what we're trying to do is to place the electrodes of our surveillance system along the natural history of viral hepatitis as an infection. So with hepatitis, you get a new infection that very often, at least for C, will turn into a chronic infection, and then that will result in mortality. So the key one to measure initially is definitely the prevalence, because that is the one you need for an initial assessment of the situation. So in fact, and you may want to be aware of this, prevalence is not an indicator of elimination. It's incidence and mortality. So prevalence is mostly important for an initial assessment. And also, if we continue on the scenario of the elimination, remember that the bar of infected is very low, but in fact the bar of anti-HCV positive will remain quite high. And this is why also from a testing point of view, we will need to address that. So the first pillar of the surveillance system is actually the monitoring of the proportion of people chronically infected. We start, if you want, by the middle. That's a C1 indicator. Then we have the C9 indicator, which is about the incidence. And for this, we need to capture a few cases of acute hepatitis, because those very few cases of acute hepatitis, the tip of the iceberg of all those asymptomatic cases, they tell you something about how people continue to get infected. And Egypt, again, has been extremely successful at capturing the small fraction of cases that are symptomatic with acute infection and understand what are the risk factors for infection. And the last one is mortality surveillance. Graham has talked to you about the mortality data. One of the things that we absolutely need is the proportion of cirrhosis and hepatocellular carcinoma that are attributable to B and C. Because from a global burden of the disease perspective, people don't die of hepatitis. They die of HCC and they die of cirrhosis. So what we need from all your countries is actually data on the proportion of patients with HCC and cirrhosis that have B or C. And that is the way that the GBD and WHO data will be improved. Just a little more detail now on the surveillance of acute hepatitis. So what we're trying to do is build on what we call syndromic surveillance, which I'm sure is in place in each and every one of your countries. What is syndromic surveillance? It's basically surveillance for acute hepatitis when people get acutely yellow and sick. It usually collects information on the basic demographic characteristics, and that's all. And that's only useful basically for outbreak detection. And outbreak detection is mostly useful for A or for E. So this sort of basic syndromic surveillance is not really useful for what we're trying to do, which is hepatitis elimination, 96% of which is B and C. So what we're trying to support is enhanced case reporting, which is surveillance in a few set of sentinel sites for real cases of acute hepatitis defined with a clinical case definition and IgM diagnosis so that we can differentiate the A from the B from the C. And that is the only way that you can have information on the trends by type and also on the risk factors for new infections. The second pillar, so by the way, I forgot to mention, but for this enhanced case surveillance, we have actually a WHO template protocol, which is now going through ethical review. So if you're interested in implementing this in your country, talk to me. I can share a draft, which is on a Dropbox, and very soon it'll be on the WHO website. So anybody want to sign into this program can just download the protocol and do it. Same for seroprevalence. We're really trying to help country in getting their seroprevalence data, because that will be usually what will trigger a program. So the reference methods, of course, will be the population-based estimate. And so we've chosen the same approach. We have a template, a survey protocol that's available. We've already pilot tested it in Bhutan and in Morocco. Bhutan has completed its survey, and Morocco is about to do it early next year. And very soon it will be a WHO template protocol available from the website, which means that if next year you want to do a survey in Nigeria, you don't have to rehire somebody and write a protocol from A to Z. You just fill the blank and write Nigeria instead of country X, and you can have a protocol ready very quickly. So last but not least, the mortality surveillance. As we've mentioned, the GBD functions as per what's called the mortality envelope. So very rarely do we have people dying from B or C, and it's written on the death certificate that they did. So what's written is usually HCC or cirrhosis, and that's called the mortality envelope. So most of your country would have some estimates of that, either real or either approximated or estimated by GBD. So what we need is to carve out the proportion of these that can be attributable to B and C. So in the context of the work that we're trying to do with the centers of hepatology, we also developed a template protocol for people to measure proportion of cirrhosis and HCC that comes from B and C. Again, this is a template protocol, which is also undergoing ethical committee review, and which by 2018 should be downloadable from the WHO website. But if you want it, I can give it to you right now, with the disclaimer that it's not yet cleared by our WHO ethical committee. So take-home message, we really want to take the elimination movement as per the principle of what gets measured gets done. We have a solid M&E framework, which has been carbon copy on the one for HIV, so we have some reason to think that it's actually the way to go about it. The data on prevention indicators can be usually collected with tools already in place, because these are health system intervention for which there's usually already data collected. But for the testing and treatment part, we need something that is really person-centered and that will capture the care of the patient, ensure the right care for the patient, and aggregation of data to generate the country-specific cascade. And that's all good and well, but we also need hepatitis surveillance according to the 3 stages of the natural history, so that we can see how these progress in prevention and care and treatment actually translate into reduction of incidence and reduction of mortality. So thank you very much. And,